on our speakers, Dr. Joseph Super and PA Deanna Michaud. Dr. Joseph Super is an endocrinologist and was in clinical practice for over 30 years. Currently, he is the medical director of Chase Medical Research and has been since 1999. He also has been a principal investigator in over 400 clinical trials. Deanna Michaud, PA, has had 20 years of experience in clinical practice, including internal medicine and nephrology. She has been a sub-investigator for 7 years in clinical trials at Chase Medical Research. Now at this point, I'm going to toss this presentation over to our speakers to begin the presentation.
Hi everyone, and thanks for joining us today. Today we're going to talk about chronic kidney disease. The first half, we're going to focus on general information, including what chronic kidney disease is, and the stages of chronic kidney disease, some of the signs and symptoms. The second half, we're going to focus mainly on prevention, how do you slow down the progression of chronic kidney disease, and we're going to talk about treatments as well.
Next.
So first off, I'd like to talk about the functions of the kidneys. What do the kidneys actually do? Their main job is to filter the blood to remove waste products such as urea and nitrogen, and also to preserve components of the blood such as electrolytes and protein. Protein is essential for our bodies. We need it for our muscles, we need it for our organs. Our body uses it as fuel. So we want to keep that protein in our blood and not spill it out into our urine. We also, how do you measure kidney function? Kidney function is actually measured by a blood test called eGFR, and this is basically a measure of your kidney function. When we're born, our kidney function is approximately, our eGFR is approximately 100, and as we age, this will minutely diminish over time. And I'm going to speak more about that in a later slide coming up.
Other functions that are very important that affect our body are particular hormones that affect our blood pressure, for example, which can cause high blood pressure if these hormones aren't controlled properly as the kidney goes through changes over time. Red blood cells through a particular hormone called erythropoietin, which is important in stimulating the bone marrow in developing red blood cells. With chronic kidney disease, if this protein is not being formed, it can cause a reduction in red blood cells and as a result, anemia. And the third problem that could occur is that normally the kidneys will convert what's called inactive vitamin D into active vitamin D, which allows the body to preserve calcium as well as maintaining bone strength. What happens over time, this functioning of changing inactive to active vitamin D diminishes, and as a result may lead to osteoporosis through other mechanisms in the body where the bone is then stimulated by something called parathormone, which brings more calcium into the bloodstream, which is needed, but also weakens the bones and unfortunately can cause fractures of the bone. Next.
So what is chronic kidney disease? This slide is a visualization of chronic kidney disease. You'll see on the right is a healthy kidney. You can see that it's larger in size. There's no scar tissue. On the left side is a depiction of a disease affected by chronic kidney disease. It's smaller in size, and there's areas of scar tissue. So what exactly is chronic kidney disease? Basically, it's damage that's done to the kidneys over time, which decreases the ability of the kidneys to filter the blood and remove the waste products effectively, and also to retain the products that we need, like that protein and the different electrolytes like sodium and potassium that we need. We don't want to get rid of those essential nutrients. You'll also see a reduced eGFR, like we talked about earlier. So as the kidney disease worsens, you're going to see that reduce in time. And also, as the kidney disease progresses, you'll also very commonly see an increase in protein in the urine because the kidneys are no longer able to keep that protein out, keep it in the blood, it gets spilled out into the urine. And we often see this especially in the diabetic population and in high blood pressure.
Next. So what are some of the common causes of chronic kidney disease, or we call it CKD? The most common causes are diabetes and hypertension. Both types of diabetes, type 1 and type 2, as well as blood pressure that's not well controlled. The third causes are a group of diseases called chronic kidney stones, where kidney stones over time can cause blockages within the kidneys and disrupt the kidney function, or autoimmune diseases such as lupus, which have an effect on the circulation within the kidneys, which prevent it from functioning normally. So approximately 75% of all the cases that occur due to CKD are due to diabetes and hypertension. Next.
So now I'm going to talk a little bit more about the stages of chronic kidney disease. There are 5 stages of chronic kidney disease. And remember, we talked about the eGFR. That's the measure of the function of the kidneys and how well it's functioning. So a normal eGFR is more than 90. And as for the protein, we really shouldn't spill protein in the urine much at all. So really, it should be about 0. So in our first stages, stages 1 and 2, we see a very mild loss of kidney function. eGFR is usually greater than is always greater than 60 in stages 1 and 2. Protein, though, we can start seeing protein really early on, even in these early stages. Might be more than 30, could be even more than that. Depends on the person and the situation of their medical issues. Stage 3 is when most patients are referred to a kidney specialist at this point. And here at this point, you've got a mild to a moderate loss of kidney function. That kidney function falls below 60. And on your blood work, you'll often see that because many labs will just report it as more than 60 or lower. At that point, if it falls below 60, then they'll start reporting a number to you. And the protein will start actually oftentimes increasing further. You might see 200, you might see 300, especially in the diabetic population, and also potentially in patients with high blood pressure and other types of kidney disease as well. Stage 4 kidney disease, now you've got a moderate to a severe loss of kidney function. That kidney function, that eGFR is less than 30, and the protein often is becoming even more than 500, 600, 700. And at stage 5, this is considered a severe loss of kidney function, less than 15 for an eGFR, and can, as that eGFR declines further, can actually result in the need for dialysis. And protein levels can be more than 750. It could be 800, 1,000, 2,000, but it really depends on each patient because it's possible to have no protein, but very, very commonly to see a lot of protein especially like I said, as the stages progress and you get to the worsening stages of kidney disease.
On a practical point, I want to comment that most patients who go see their doctors, you have a blood test done, which will measure your kidney functions, which calculates what's called the GFR that Deanna has been talking about. However, I would say most of the time, doctors do not check the urine as frequently as they may need to, depending on how long you've had diabetes, how long you've had hypertension, which can combine together to cause some of these different stages that Diana was talking about. So typically, a urine sample, when you go to see your doctor, can be checked very simply with a dipstick. You can go back to that previous slide, please. With a dipstick that can give us an idea of whether or not there's actually any protein that is very simple, says 1+, 2+, 3+, and that will be an indication as to whether or not a more specific test has to be done to determine the actual amount of protein. Here, we're saying in general protein, the actual component of that protein is called albumin, and that's a very sensitive protein that is detected in the urine. And by doing that, and that is done in various ways, sometimes the kidney specialist or your own internist or family practitioner may collect a urine for 24 hours to get a very exact idea of how much protein or albumin you're producing in a 24-hour period or in a shorter time. So it's important that if you haven't had a urine test at any time, you should request that from your physician and discuss that with him as well. Don't you agree, Deanna?
I agree. And we're going to be talking about medications in an upcoming slides that also are used to help reduce the protein in the urine and slow down kidney disease.
Yes. Next. So now we like to just touch upon what are some of the signs and symptoms of CKD or chronic kidney disease, because there are times when people go for a long period of changes in their blood and their urine tests, but they may not feel any different. Now, naturally speaking, the longer you have your diabetes that could be out of control or blood pressure that's out of control, you'll begin to feel some symptoms. You'll feel some of the things that were listed here. Now, fatigue is a very general symptom, which can be due to a number of items. Excuse me. Part of it could be related to the fact that if you're spilling too much protein in your urine, that would certainly not allow the muscle mass to be maintained. So weakness could be muscle weakness. But at the same time, if there's a disruption in the production of that hormone that I mentioned earlier, erythropoietin, which helps to maintain your red blood cells, one can become anemic, and that can cause fatigue. Now, the third thing that is the most serious of all is what we call edema, or buildup of fluid. So typically, if you see your physician, you may notice sometimes he may be pressing against your ankle in your legs, particularly on the left side. The reason he's doing that is to see whether or not there's any fluid buildup when he presses into your ankles, and which is something you could also do yourself at home. If you make a push on the ankle, if there's an impression of your thumb or your finger that's left in the leg, you know there's fluid in there, which is not normal, because now the body is having a difficult time getting rid of fluid. And one of the reasons why the fluid is being developed is because you're actually losing protein. So protein keeps fluid in your system. When you start losing protein, it's unable to keep the fluids within the circulation, and fluid goes out. And as a result, over time, the more fluid that builds up first in your extremities, meaning your legs, it can build up in the rest of your body, from heart to lungs to your abdomen. And those just indicate the severity of the kidney disease over time. Now, the volume of urine that one produces during the stages of CKD will vary from large volumes to ultimately smaller volumes, again, due to the severity of the CKD. Now, general symptoms such as nausea and vomiting can be related to the fact that those waste products that we're talking about, blood urea, nitrogen, build up and can cause changes in the brain that can give someone the sensation of nausea and ultimately vomiting. And lastly, near the later stages of CKD, because inactive vitamin D isn't changed into active vitamin D, osteoporosis can form, as I mentioned earlier, and lead to bone fractures. Now, bone densities can help to determine whether or not someone is developing osteoporosis, and it's a good thing to consider and ask your physician to check as well. Next.
So now I'm going to talk about some of the general tips to slow down kidney disease. So like we've talked about in the past, diabetes and high blood pressure is the most common cause of chronic kidney disease in the United States. So it's very important. One of the ways to help prevent is to keep these disorders under good control. So keeping that A1C less than 7 or potentially lower. To keep that blood pressure less than 130/80 or less, depending on age can be a determined factor, but oftentimes 130/80. Control those lipid levels, that bad cholesterol, LDL, we'd like to see that down, reduced. Statin therapy, even with LDL that's within a technically normal range, actually statin therapy can actually be very beneficial to people with diabetes, people with high blood pressure, in the prevention of heart disease and other forms. And some of the other things we want to think about is avoiding some medications that can potentially harm the kidneys, depending on which stage of kidney disease you're in. Some of the anti-inflammatories that are commonly taken for arthritis, Aleve, Advil, ibuprofen, Motrin. Those are medications that you may need to limit or avoid altogether, depending on the stage of kidney disease. What do you think, Dr. Suver, about these recommendations?
I think in general, they're very good ones. However, just as a point of learning about what the A1C, for example, these guidelines of less than 7 was brought up by the American Diabetes Association based on preventing hypoglycemia or unawareness of hypoglycemia that was found in several studies. However, the American College of Endocrinology will find that the recommendation is lower, 6.5% as an ideal number. Now, of course, this is all in the context of someone watching their blood sugars very closely in order to avoid those low blood sugars that most diabetics are fearful of developing low blood sugars. Now, the blood pressure has been contested in terms of what is the ideal blood pressure for many years. Finally, the experts have gotten together and they came up with this 130/80. However, it needs to be understood that a blood pressure will vary throughout the day depending on one's exercise or not exercise or activity at any one time. So, for example, if you're walking up a flight of stairs quickly or not, and then you sit down and you quickly take your blood pressure, it may show that it's 150/90. Now, that doesn't necessarily mean it's abnormal. It just simply means that your body's reacting to the exercise that you did. And if you sit for a while, that should come down to that 130/80 range, ideally. There was also a lot of discussion about white coat syndrome. And, if you have white coat syndrome, meaning if you go see a doctor or your dentist and your blood pressure goes up, just to ignore it. Well, that's not the case anymore. That white coat syndrome is also found to have potential damage effects on the circulation, because one doesn't know how many white coat syndromes one has in the course of a day. It may not necessarily be seeing your doctor. It could be your mechanic upsetting you or someone else in the family upsetting you. That will cause your blood pressure to go up. So it's important that the blood pressure is normal as long as possible during the course of the day. Now, statin therapy has been shown to be of a significant benefit for diabetics because we know that, naturally speaking, when the blood sugar is elevated, it can cause inflammation within the blood cells, within the blood vessels. And statin therapy is definitely shown to reduce inflammation within the blood vessels, which helps to reduce the possibility of plaque buildup, which is of concern, of course, from all parts of the circulation of the body, from the eyes. Diabetes is the leading cause of blindness in the country, so we want to reduce that possibility. Heart disease, as well as CKD, which is the topic that we're discussing today. So I have to say that although it may be overwhelming for most people to be on several medications, they all have their importance in preventing the development of CKD and also the other complications that we see with diabetes and hypertension.
Absolutely.
Next. So now we want to just touch upon some of the advances that have been made to help treat CKD, and more importantly, to prevent the progression of CKD. This is something that's developed over the past 40, 50 years. The first group of medications, called ACE inhibitors or ARBs, is really an eponym for the hormones that are involved in development of hypertension associated with the kidney's function. So there are hormones that we can help reduce so that they prevent the elevation of blood pressures, and they're called ACE inhibitors or ARBs. The medications that are listed there, lisinopril, losartan, valsartan, olmesartan, these are medications that have been well recognized to help reduce the progression of kidney disease over time. Now, some people have side effects, and your doctor will determine whether or not it's ideal for you, but most people can take these medications with little problems. Of course, there are issues if you have stage 4, stage 5 CKD, as Deanna had mentioned, where the potassium levels may be too high. In this group of medications, potassium may go up if the dose is too high, but your doctors will be able to monitor that carefully. Now, the second category are these medications called SGLT2 inhibitors. What that does is also a different compound that's been recently found over the past 10 years to help reduce the blood sugar, primarily by getting rid of sugar within the urine through the kidneys. And what was found as a side note, that it also helped reduce the progression of kidney disease at the same time. It wasn't something that they expected, but they found that, oh, not only does it help reduce blood sugars and help the A1C, oh, by the way, it is also helping the progression of kidney disease. And subsequently, tests are being done, studies are being done to show that it also helps heart disease potentially as well. The third group of medications, MR antagonists, was also recently found to show also to prevent the progression of kidney disease in combination with any of the medications listed above. There are presently studies going on to show how the combination of an SGLT2 and an MR antagonist can be even more beneficial than just taking an ACE inhibitor alone. So studies are going on, and we're doing those right now here at Chase Medical Research. And at the same time, to note that, as the slide is mentioning, we're involved in the development of all these medications through clinical trials over the past 20 years. So I would suggest that if you're not on any of these medications and you think you have CKD, please bring this to the attention of your doctor if he hasn't discussed it with you already.
Right. It is an exciting time, I find, in the diabetic population, CKD, and heart failure patients, that these medications that were never available before, treatments that we've only had a limited number of treatments, and now it's expanded the horizons of what we can provide and treatments that we can provide to patients. So I find that quite exciting.
It is. It is. It's another option for patients who in the past did not have this option to help prevent the progression and ultimately try to avoid getting dialysis. Next. So as we were just talking about, the ongoing clinical studies that are going not only here at Chase Medical Research, but throughout the country, are looking at how do we deal with chronic kidney disease, particularly as it relates to patients with diabetes and without diabetes, because we want to look and see what medications, if there are some potential benefits for both groups of patients who've developed CKD. Now, in the meantime, we have clinical studies at this going on, looking at other aspects of diabetes, whether it's from neuropathy or looking at how it affects cholesterol, how it affects your A1C, how does it prevent heart disease in the future. These are all ongoing studies that we're doing here at Chase Medical Research, in addition to looking at high blood pressure, cholesterol, and now very popular as it is, looking at various medications to help people lose weight who are obese. And with that, I'd like to conclude our discussion and hope if there's any questions, we'll be able to answer those as best as we can.
And thank you everyone for joining us today. We really appreciate it.
Thank you.
Thank you, Dr. Super and Deanna. Let me see if there are any questions here. So we do have a question. It says, any benefits of Mounjaro or Ozempic relative to CKD?
Yes, yes, there has been some new clinical trials that have shown that there has been a benefit for some aspects and some stages, primarily as a prevention, but more importantly, it has a benefit for the heart. So that has been shown clearly that it has cardiovascular benefits.
And we do have some ongoing trials as well that are delving more into the chronic kidney disease and whether or not, how much it's going to slow the progression, if it's going, Mounjaro in particular, looking to see if that's going to happen. And the preliminary studies are very exciting so far.
Thank you. Let's take a look to see if there's more. Now, there's a question that does ask, do you recommend blood transfusion for hemoglobin 11 and fatigue?
Well, if the question is based on having CKD and you have a blood count, or assume you're saying that your hemoglobin is 11, no, we don't recommend getting a blood transfusion. There are other ways of raising that hemoglobin through some form of injection that is basically simulating what the kidney produces, erythropoietin, and that comes through an injection that you can get at your doctor's office. Certainly transfusions are not recommended unless those other methods don't work, and it's very late stage anemia, where it's almost at the point of someone requiring dialysis. But that's in a very severe situation, don't you agree?
Agree. And a lot of the times, even with the injections, typically they're not warranted until the hemoglobin falls below 10. So usually at 11, they might recommend some iron therapy to start. And then with following you closely with your blood work every so many months to make sure that that's not dropping further.
Yes, I agree.
And then with the transfusions, especially if you are at a later stage of chronic kidney disease and you are thinking if transplant may be in your future for example, they really try to have you avoid blood transfusions as much as possible because you can develop antibodies that then make the transplant possibility a little bit harder, a little bit of a harder match. Again, that's a little bit more detailed, but that certainly is something that the nephrology world thinks about as the kidney disease is worsening.
Good point.
I do not see any more questions here. So if anybody in the future has any more questions, please feel free to call us at 203-419-4404, or you can also email us your questions or anything regarding clinical trials at research@chasemr.com. And we thank you for tuning in, and that concludes our webinar today. Thank you, everyone.
Thank you, everyone.